You're watching Supporting Your Registrar to Study Smarter, Not Harder. Produced by GP Supervision Australia and presented by Dr. Chris Starling and Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
Chris and I are very excited to present this, I think it's fair to say, eagerly awaited topic around study skills. It's hard enough to prepare for fellowship exams, and we're not trying to make things more burdensome. In fact, in many respects, just trying to make it more streamlined and more effective the way registrars study and the way supervisors can support them to study. So my name is Simon Morgan. I'm a GP, a medical educator with the RACGP and with GPSA, and I'm joining you tonight from a Wabakal country. And I'll allow Chris to introduce himself a little bit. We work very closely together in the Newcastle office of the RACGP, and Chris is the Regional Head of Education here in our region and has a very strong and informed interest on this topic. So it's wonderful to have him along. So at this point, I'd very much like to hand over to you, Chris.
Thank you very much, Simon. So yes, welcome everyone. And as Simon has already introduced, my name is Chris Starling. And yes, I work as the head of training for RACGP in the Hunter Manning Central Coast region, but I've also worked prior to the transition this year with ACRM as well. So I have a bit of understanding of both programs. So a topic that's very close to my heart is around learning strategies and how to effectively study both as a registrar and at any stage in your career, really. Basically, I wanted to go through some ineffective study strategies, then talk about how to apply evidence-based strategies, both in terms of exam preparation for either college and also as lifelong learners as we move forward in our careers, how to develop an effective study plan, and also for supervisors, how to incorporate an evidence-based study plan and strategies into your in-practice teaching. So before we talk about the effective study strategies, I think it's really important for us to consider, where is the learner up to? Are they in the right position to actually be even implementing some of these effective study strategies? So I've included a whole different range of areas or prerequisites here, I guess you could call them, around, is the learner getting enough sleep? We know that you need enough sleep in order to form long-term memories and for good retention. What's the diet like? Are you getting enough exercise? Are you effectively managing any underlying medical conditions that could impact your ability to study? What's the social situation? Are you planning to have a baby in the next 6 to 9 months? How does that fit with studying for an upcoming exam? What's work like? Do you need to drop to part-time, or are you doing a heap of locum shifts on the weekend, which is going to completely take up all your time and you're not actually going to be able to fit in effective study? Are there pre-existing learning disabilities like ADHD, dyslexia, specific learning disorder that actually there are specific strategies that you should have in place? And if you don't, should we look at that before you start down that path of preparing for exams? And the last one there I've got is performance anxiety. This is something that, if you've had issues with performance anxiety in the past, this is something that we should start working on now before you get to the exams in, 6 to 12 months' time. So it's just that idea of looking at the whole learner. In the guide that Simon talked about, we are going into some of these topics in a bit more detail.
Chris has alluded to the guide, and I think I didn't introduce that as fully as I might have at the beginning of the webinar. We're very, very excited tonight, I guess in a sense formally, to be launching a very newly published resource for you, for supervisors, for registrars, and it's in the style of the GPSA guides, very practically accessible, evidence-based, and something that we really hope you'll avail yourselves of in whatever position you're in, supervisors to support their registrars and registrars to help prepare. Chris has just talked about the whole learner. It was such sort of broad, important context that we thought, that really needs to go right at the beginning of the guide. And so Chris has touched on all those incredibly important areas very, very briefly. But please, the guide follows the format very closely. And in fact, the second part of the guide is what to study, identifying learning needs. And as the guide says, we don't delve into this in any depth at all. We have a resource, in fact, 2 very, very good resources. One, a webinar that was run a couple of years ago on this topic, how to identify learning needs in the registrar, and the other, a guide on this very topic. So that's a really important area of educational practice in and of itself. But clearly, everything we're talking about must be based on a good understanding of the registrar's learning needs. Without that, you're really operating in the dark. And again, I think we'll talk about we a lot, and we does refer to the supervisor supporting the registrar preparing for exams. And so our Johari window, or the learning needs iceberg, we need to be aware that most of our learning needs are unknown, and many of them are hidden. They're unknown unknowns. They're very hard to identify. And the supervisor has a really important role in their supervisory clinical oversight capacity to help uncover those hidden learning needs for the registrar. One resource I think is worth pointing to is the GPSA 4R Learning Needs Assessment tool. There are many, many, many ways that supervisors and registrars can help identify learning needs. This is another really useful one that looks at the broad domains of practice, which again, if you're not aware of, we'd ask you to have a look at. And we'll move, as we said, to the how-tos. How can we study effectively?
So I guess starting off with study myths or ineffective strategies. And I'm sure a lot of these look familiar to most of us. I'm sure you're reading some of these and going, oh, wow, that's how I got through my medical exams. But it's starting on top. So I think learning should be easy and effortless. So I guess the key with this one is that we do gravitate to things that are easier. So when we're studying, we think if this is easy, it must be working, right? But in fact, what's been shown is that we need to work hard to learn. So we want to seek out things that do make us think more. It's that whole attitude, no pain, no gain. So you think of the brain like a muscle, you need to work hard in order for it to grow. Or I guess to store, it's not going to grow, it's going to store information. So cramming, no evidence for it. The other word for it, or the name for it, is mass practice. So this idea of doing a whole lot of study right before an exam, what that has shown is that it might lead to short-term gains, but it doesn't lead to long-term retention of knowledge, which is exactly what we need as GPs. So we need to be setting really good memories and using study strategies to give us that long-term knowledge, because we're going to need it for the rest of our careers. The next one, which I hear a lot from my registrars, so, I read Murtaugh 3 times in the lead up to the exams. You think, oh, that's great, but it's not an effective approach. So reading and rereading the textbook, what it leads to is this concept of the illusion of knowing. So every time you read and reread, a passage of text, you may think that you're understanding it because you recognize what you've read previously, but it doesn't actually mean that you've understood it to a level that you're going to be able to apply it in practice. So that's probably the one that's got the least evidence for study. It's just that simple reading and rereading technique. Highlighting. So highlighting is interesting. So a lot of learners do it. And I think the key here is that if it's just a passive technique you're using where you're reading, you're highlighting everything, or you're just highlighting things that you think are important, it's actually been shown in studies that is not effective for learners. What may be effective, and again, there's not heaps of good evidence on this, but if you were to use the highlighter, so read the text, but then go through, think about what you've just read, compare and contrast different aspects of the text, and then highlight some of the features in the text. That may be effective, but you have to do something with it. So you can't just passively read the text and highlight as you go. That's been shown to be ineffective. Learning style. So this might be a bit controversial for the group if there's any educators out there. A lot of educators bang on about learning styles and that you should adapt the learning style to the learner. So, you might be a visual learner or a tactile learner, whatever. Again, there's actually no really good evidence that adapting a learning style to the learner makes any difference. Okay, so what they actually show is you should use a variety of different learning techniques. And if you're learning for a particular exam, so like a verbal exam, then you should do that as part of your study program. And finally, last 2 points. The second last there being, I'm a good judge of my own competence. So you might have heard of the Dunning-Kruger effect. So quite simply, this idea of that the least competent learners actually overestimate their ability more than the more competent learners. So we're not good at assessing our own competence. So the way we can get better at that is through feedback from our supervisor or colleagues, calibration from our colleagues, so being in small groups and learning from each other, comparing ourselves to others, and reflection. Okay, so, but yes, we aren't good judges of our own competence. And then finally, this idea of a fixed mindset. So you may have heard of this before, but this idea that your talent and ability is fixed. So you might say, I'm not good at art and I'm never going to be good at art. Whereas a growth mindset would say, well, actually, if I practice this, I will become better at it. So it's changing that mindset within the learner. All right, so that's some of the myths and ineffective study strategies. Now let's talk about evidence-based strategies. So there's 6 strategies here. So I put up there the learning scientists. If you're at all interested in further reading and where a lot of this evidence comes from, I'd really recommend you either listening to their podcast, or they also have a blog which follows on from the podcast. So they're a group of cognitive psychologists who coined 6 effective strategies, which is on the screen. And I'm going to go into each of those separately. I've also put up a picture of this book. It's called Make It Stick by Peter Brown and colleagues. Excellent book. If you're interested in the science of learning, I would really recommend having a read of this. And some of this information from this talk also comes from this resource as well. So let's start with space practice. So the first one on the list. So this one's been around for a while, but basically, as simple as I can put this, it's this idea of spreading out learning over time. So rather than doing a topic, so spending 10 hours on learning about COPD, you actually spread it out over time. So you do small chunks regularly, and that by doing that has been shown more effective in terms of long-term memory and retention. So very simple technique and very easy to do. You may have come across this graph previously, and this was developed as, again, a very simple graph, and it was developed by a German psychologist back in the late 1800s, and his name was Ebbinghaus. And basically, it's coined the forgetting curve, and what it shows is that from the point where you learn something, if you do nothing else, over time, you'll forget that information, which is pretty simple, right? But it's quite a powerful picture as we move through this talk. Now, how can you offset that? So the next effective study strategy that's talked about is retrieval practice. And this is one that you've probably all been doing throughout both medical school and in vocational training and beyond. So this is that idea of bringing information to mind. So this is what you're doing when you do practice questions, or if you get a blank piece of paper and you just write down as much as you can about a condition before looking at the book, or if someone's doing case-based discussion with you and asking questions about it. There's lots of different ways you can do it, but it's one of the most powerful and best researched strategies that we have. One of the things you can do, and again, the registrars that are coming through now seem to have used this a lot in medical school, and that's the use of flashcards. So I put there's lots of different flashcard apps there. I put a picture of Anki app, which is a nice one that actually incorporates, so that you can make your own flashcards, but it actually incorporates space retrieval, which we'll talk about in the next couple of slides. And there's another one called I Do Recall, where you can do flashcards, but you can also link it to your study notes, which is quite cool. And they both integrate those effective study strategies as part of their programming. With flashcards, there's 2 points that I'd want to make. So one is that the benefit in flashcards is not only in the use of retrieval practice, so you write the flashcard and then you test yourself later on, it's also the process of actually thinking about what to put on that flashcard. And the other benefit that I really encourage you to do is to take it to that next level. So writing what's called conceptual flashcards. So rather than just rote memorization, so where you ask a question and it's a simple answer, write cards that actually ask you to compare and contrast things. So you're taking it to the next level. So for example, you might write a flashcard and say, compare the key features for COPD versus asthma. So you have to actually think about, okay, what are the key features on history, examination, investigation, management for each of these conditions, and how do they differ? How are they similar? So it's just taking it to that next level rather than just literally going, what's 3 times 3? Oh yeah, 9, which would be done in a school setting. On this slide, I've just given some examples. So these are generic retrieval practice questions you could do in a general practice setting. The reason I've written them like this is because they're very similar to how you would be asked a lead in a exam question. So, differential diagnoses or key features on history, examination, investigations, non-pharmacological versus pharmacological management. So it's basically just an example of how you could write questions in a standard way when you're doing your retrieval practice as part of your study. So we've talked about space practice, we've talked about retrieval practice, then there's this concept of spaced retrieval. So the idea behind here is that, so you learn something and then you do retrieval practice quite soon after it. So let's say a day or a week, and then you do it at, let's say, a month, and then you do it, say, at 3 months. And the idea is you're spacing out that retrieval practice. And it's been shown, as you can see in that graph there, to offset that forgetting curve even more. So there's different ways you can do retrieval practice. This is from one of the blogs on the Learning Scientist podcast, and it shows a really nice picture there of the 3 different schedules that have been evaluated. So the first one there, we've got the expanding learning schedule, where you do your initial learning, review it quite quickly with retrieval practice after the learning has happened, and then you have a gap, and then you do it close to the test. You've got one called contracting, where it's a bit more pushed towards closer to the test. And then you've got an equal one where it's spread equally. The expanding and the equal learning schedules have been shown to be superior to the contracting learning schedule in research studies. So I have to admit, I'm a fan of the expanding learning schedule. So doing some retrieval practice maybe a week after you've learned something, a month, and then 3 months if you've got a 6-month sort of study plan. But certainly you can do the equal as well. As I said, there's a link there in the blog if you wanted to read more about that. But this is the the retrieval practice side of things is definitely where the most evidence is for long-term memory and retention. Now, the next strategy that's on the list is elaborative interrogation. So this is that idea of reading to understand. So as you're reading through the textbook or a journal article, it's rather than just reading it and just, writing down notes and stuff, it's that idea of while you're reading, thinking about, asking how and why questions, really thinking, trying to make connections, so this is happening in this condition, how's that different to that condition, and how are they connected? And so it's a lot harder. It's what they call a deeper learning type technique. So it's not something you can do a week out from an exam. It's something you have to start, do as you're in practice, while you're studying, before the lead up to your exams. And it shows that you'll have much better understanding. You'll be able to apply that knowledge to different situations a lot better. Also called elaboration. So these are some examples, and these are out of the guide, of questions you can ask yourself. Both the registrar can ask while they're studying, but also the supervisor can use this like a practice setting as part of teaching to do some elaboration. So you can see there on the left, asking these questions like, why is this true? Why does this make sense? Why is it true for condition A versus condition B? Or like hypothetical situations, which you're probably already doing. You're changing some of the factors, maybe as part of random case analysis, about the cultural context or the location, the age of the patient, the gender, etc. These are just examples. There's lots of different ways that you can do elaboration in practice. So dual coding. So this is probably one of my favorites. So this is the idea of combining both words and visuals to improve memory and learning. And this is to do with different pathways in the brain. You see it a lot, and it's actually being done a lot more. And what I've done here is given some examples. So the picture in the middle of the man's head, I haven't given you the diagnosis. It's out of Murtaugh. If you look at that picture, is there a diagnosis that comes to mind? Let's just say this person was getting severe headache as well. So he's basically got cluster headache. So you can see that this is a really powerful tool while you're studying, creating pictures. It can be as simple as, you're studying a presentation and you draw a stick figure. On that stick figure, you draw the classic symptoms or the examination findings or whatever it is, so that you're making a visual image connected with the text. On the right there, this is from a Twitter handle by Manual of Medicine, where they intimately put up these pictures, which I find they're just great. It's got vertigo and then it's got pictures to show you, break it down into time, or there's lots of different versions they've got on there. There's also some podcasts like this one here, the Curbsiders podcast. Fantastic podcast, by the way. It's American-based, so you have to consider that in terms of medication dosages and guidelines and so forth. But what they do really well is they have the audio podcast, and then afterwards they do an infographic, which has basically pictures and a summary of pertinent information from the podcast. It's really good. I'd really recommend having listened to it. The other ones I have there are some different websites where they use different forms of images. There's a bit of a fun one here called Celebrity Diagnosis, which links medical conditions to specific celebrities. There's a couple of other ones, Picmonic and Sketchy, where they draw pictures to help remember different conditions and presentations. So lots of different ways you can use it in practice. Mind and concept maps are another form of dual coding, and you've probably used it a bit as part of your study over the years. Again, I'm a big fan of it. So this is just an example of how you could do a mind map like as pictured with vertigo, breaking it down into syndromes, or you might break it down into whatever framework you like, and then the differentials. A concept that takes it one step forward is, we've talked about retrieval practice. Well, there's this idea of retrieval mapping. So you take a blank chart, like let's say that we do a flow chart like that, it's completely blank, and then you write vertigo, and then you try to retrieve that information before you look at the textbook. So you write down as many differentials as you can, form a framework, however you want to do the framework, and then you go back to the book and you see what you missed. So that's a really powerful tool. So it's a form of retrieval practice called retrieval mapping.
Chris, it's about this time that I start to think, man, this is hard. And I think I'd just go back to that early point you made, that the true point, and the more I've been involved in this work with you, is that it is hard, and it kind of meant to be hard. But if it's hard, it's working. And I think the evidence is around, if it's easy and very straightforward, it's probably not sticking. So as you're probably thinking, oh gosh, there's quite a bit in this, that's the point. This will make it stick. This will make you learn effectively, not just to get through exams, but for lifelong. So what are those last couple of evidence-based techniques that the learning scientists refer to?
And I agree with Simon. I think, and I've gone through these quite quickly. It did take me a while to sort of think about these topics. And that's why after this session, having a read of the guide, get some more information in there, and it will make a lot more sense the more you think about these techniques. And I think one of the pre-questions was around this idea of, is it one size fits all for everyone? And I would definitely say no. I think you have to take these strategies and you have to apply them to your own approach to study. It's definitely not a one size fits all approach to study for individuals. Last two effective strategies that are listed by the learning scientists. So interleaving, this is quite a simple concept, but it's this idea of switching between topics as you go. So they have this idea of block practice. So if, let's say you spent 10 hours just learning about COPD and got really good at that, that's not what we want you to do. So we want you to, in your study sessions, break it up. So the easiest way to do this is actually to take a presentation approach. So you might do a presentation of dyspnea. So you learn about COPD, asthma, pneumothorax, whatever it is, And so you're switching topics and you're making connections between those different, and for us, that's making connections between different conditions and presentations. So that's interleaving in a nutshell as a technique. And the last one, concrete examples. So again, when you read about it, it talks about having examples of an abstract idea or concept. So how does that apply to us as GPs or GP trainees? So the way I think of that is, as you're learning, as you're going through your day, is to gather examples of different real life patients that you've seen and then make links between it. So if you're learning about a certain complex, so let's say you're learning about macular papillary or rubella, you want to have lots of different presentations of that example. So you don't just want one example. You don't just want the classic rubella presentation. You go, that's how it always presents. You want to go, okay, but it presented like this for this person, this for this one. And so all the variations that we see as general practitioners, so have lots of different examples of a particular idea or concept. All right, so other study methods. So I've listed some other study methods here, which are also listed in the guide in more detail. So I won't spend a lot of time on them because you could probably spend a good chunk of the talk on it, some of these that I'm going to go through now. So mnemonics, very useful. You will have used them in medical school. You don't rely on them completely, obviously, but they're a good adjunct to the rest of your study methods. Deliberate practice. So you may have come across this. This is a really, really important concept to know as a supervisor and as a registrar. So in addition to what you're studying at home, there needs to be this deliberate practice that happens, where you're seeking cases, whether it's online, in textbooks, in practice. And the path of becoming an expert diagnostician or clinical reader is by doing lots of cases, and you need that internal motivation to improve your performance, right? So it's not just looking at lots of cases by yourself and going, yeah, I got that, that's fine. It's actually, that's just where the supervisor gets involved as a coach. It's actually giving you feedback in order for you to do reflection on, how did I go with that clinical reasoning episode I just did in relation to that patient? How can I improve? And that constant repeated case discussion, etc. So lots and lots of writing about deliberate practice out there. So have a read about it in your own time. Metacognition. This is that idea of thinking about your thinking. Simon talks about it in the context of clinical reasoning. So also in the context of studying, you can use it. So it's very important and sort of links very much in with reflection. And we all know that reflection is one of the core competencies as a doctor, and particularly as a GP, that idea that we reflect. So, when we have an encounter with a patient or an exam, we think about, what did I know before? What did I learn from this encounter? And what will I change in the future? This is a key skill that the supervisor can be involved in their in-practice teaching sessions with the registrar, encouraging reflection and really teasing out some of those key themes. The last three there I've got is rehearsal. So this idea of doing role play, low fidelity simulation. So practicing, different conversations, practicing how would I ask a history in this situation. So person comes, you might say that registrar in your study group, person comes with dyspnea, do the history for me. So you rehearse that history taking, focus history taking with the patient. Audio recordings, this can be both podcast, but it can also be where you can record your voice, record your notes into whatever device you're using, and then listen back to it while you're driving. There's some apps like Speechify, I think it's called, where it actually converts text to audio, so you can listen to it if that's how you prefer to learn as well. So many cool ways you can integrate this stuff. But I think with podcasts are awesome, but you do need to do something afterwards. So like if you're listening to a Curbsiders podcast on COPD or a similar topic, it's that process of when you come home, so you're driving, for instance, you come home, you actually write down some stuff, and then you revisit it, and you have a look at their infographic in a couple of days' time. You maybe write some questions for later retrieval practice or something. So you're doing something with that knowledge that you've just gained, rather than just listening to podcasts and doing nothing else. Finally, on that one, I've got gameplay. So this is really big in some education circles. So it's this idea of making learning fun. So maybe doing fun quizzes, or you may have come across the clinical reasoning game. So that's been really popular, certainly in New South Wales and ACT. Lots of different ways. So it's just integrating different fun aspects to learning. But I don't think it should be the only thing. It's just that these are things you add to the whole picture. So there's lots of different study strategies out there, but I've just pulled a few together here that are particularly useful. This one's called the horizontal reading exercise. There's a remediation textbook I've referenced down there, which is excellent. It may be called other things in different circles. I'm sure you've come across this in different talks before, but the idea here is that you start with a blank table, you write the presentation on the top, you put some differentials across the top line, and then down the left-hand column there, you have epidemiology, history, examination, investigation, management. And the idea is that you write down the key features for each of those conditions, and then you compare and contrast. So this is something you can do as a supervisor of your reg. So you can just draw up a box. You know, they've been learning about neurology or vertigo last week. Say, okay, let's do some retrieval practice. Write everything you know in this box for me. And then together you go, well, how does labyrinthitis differ from vestibular neuritis? What are the key features that make them different? If you saw this patient, how are you going to differentiate between those two conditions? So it's taking that to that next level. You're not just saying, oh, I can list off the key features of labyrinthitis, BPV. You're actually comparing and contrasting the two conditions, which is that higher level understanding and what most of the exams are testing for GP training. The other technique that I think is particularly useful is this technique for taking notes in lectures. You can also do this format when you're taking notes when you're at home studying. But it's called the Cornell note-taking method. So it's from the States. It was developed by Professor Port. He basically just divided the page into 4 parts. So had the title of whatever they were learning about at the top. As the session or whatever you're learning from is going, you write questions on the left-hand side, which you can use later on. Some key thoughts on the right-hand side, and then a summary at the bottom of the talk. So when you come back to retrieval practice, you cover up the main notes page and you look at your Q questions. And the idea is you've written some questions to generate that recall, and then you can look at your notes to see what the answers were. It's a nice, simple way to structure your notes, and it can be useful for later on study. And then the final one in this section we put was study groups. So again, this is a very individual choice about whether you find study groups useful, but I think if you are going to do a study group, you just need to make sure that you're an active participant. So it's not about just turning up and just listening to other people teach you. You want to make sure that you're involved, so you're teaching stuff to other learners. There are benefits in terms of if you're doing role plays or you're doing case-based discussion that you can calibrate yourself against each other. You do get exposed to different learning styles and area of strength. And I think if you set it up correctly, there is that accountability. So if you know you have to present at the next study group session, then you're more likely to do the work. I think these are good. You can integrate some of the effective study strategies that I've talked about. So you can, as a group, you can say, okay, guys, we talked about this topic last week. Let's do a bit of retrieval practice together. Or you can, as if one of your colleagues is presenting a case, you can use some of those questions from elaboration to really test their knowledge and try to get them to really think about how and why things happen with whatever condition they're presenting. If you're teaching a session, make sure you're doing dual coding. You're putting up pictures and you're putting up mind maps and different techniques as well. So it's just integrating that. And supervisors can do that if you're doing in-practice teaching as well, which we'll talk about in a later part of the talk. Okay, back over to Simon.
Thanks, Chris. I think really this section, the most important thing is that as a registrar, you develop a study plan, or as a supervisor, you support the registrar to do this and actively review it. And this is our terminology, not so much what you'll find probably universally written, but for us, a study plan requires 2 things: a weekly timetable and also a schedule over the period of time they're planning to prepare, ideally 6 months minimum. So the study timetable needs to be developed. The adherence, I think, to regular study is significantly increased when this document exists. And so as medical educators, we really insist on this being developed. And as supervisors, I'd really, really strongly encourage you to say, okay, your exams are coming. Can I have a look at your study timetable? Gee, it looks like you're working pretty hard. You've documented that you're doing a lot of after hours work, or with the new baby, it sounds like that's going to be a bit ambitious. Do we need to talk about all those other whole learner things that Chris mentioned at the beginning? The weekly timetable needs to incorporate appropriate breaks, but within the blocks that people are studying, the evidence would support shorter periods of study with regular breaks. So there's this so-called Pomodoro technique, 25 minutes and 5 minutes, and doing cycles of 4. Patsy Tremaine, many registrars and supervisors may know of. She's done a lot of work in remediation around registrar exams. She talks about longer periods, 50 minutes with a 10-minute break and maximum 4 hours in a block. And talks about there are night folk and there are morning folk, but that the morning may be more effective to study. The timetable itself, it's really, really very much just this is what the week looks like. These are my commitments. This is when I take the kids to sport. This is when I'm driving to work. This is when I get out of bed. And what's left, I need to also be able to do some physical activity and some downtime and eat and sleep. And then how do I structure my study? So that's a really important document that we encourage to be developed. And in terms of the study plan itself, that's over the period of months, we talked about learning needs, and another resource or group of resources is really what the curriculum holds, what's going to be in the exam. And you might say, well, that's a very, very, very exhaustively large document. Yes, but we can consider the ICPC 2 type categories, how frequently things present in general practice by body systems, skin, more common, say, than eye presentations. They're all important and they're all likely to be asked about, but you're going to get more dermatology than ophthalmology questions. And so those sorts of things can help drive a study plan, as can a document like the old GP Synergy study matrix, which is really a list of conditions and presentations. And so similarly, we would encourage registrars to develop a study plan over the period of time they have available. This is a draft one over 6 months. It lists a range of disciplines. We have included, so this is very much a mocked up thing, but you can see we've included some in orange practice examinations. And so they may help recalibrate particular areas of focus if you realise that you're lacking in some areas. And it also includes the spaced retrieval. So then this is a registrar can individualise this to say after a month I'll do some questions or I'll review my notes on a particular topic. I think that's probably enough, Chris, on that. This is a very individualised document. It's a critically important one, and we would really encourage supervisors to sit down with registrars and help them develop this and monitor this as they're preparing.
And I think this looks a bit overwhelming when you first look at it. And the reason we put this together is because when you talk about spaced retrieval, you go, it sounds really simple on a slide, but then when you sit down, you think, oh, there's so much to learn in general practice. How am I ever going to set up a spaced retrieval plan? And so the idea of this was to say, it's actually not that hard to do. If you look at it, so basically you just, you did cardiovascular. So this is ICPC code based, but you can set it up as per your acronym curriculum or your RACGP curriculum, whichever fellowship you're working towards. And, you did cardiovascular in the first week. You review what you learned in a week later, a month later, and 3 months later. So it's just setting it up like that. So it's just showing that it is possible, as long as you keep it as simple with big headings. So you don't want to list every single thing that you learn in week 1, because you're never going to be able to get that into a useful timetable. The next slides talk about something called the script study technique. So basically, it was just a way of showing how you could apply some of these evidence-based strategies into your study. You don't have to use this, because I think each individual needs to utilize these strategies in the way that works for them. So, bit of background. So when we talk about script, we're talking about 2 things, illness script and management script. So illness script, the easiest way to describe this is I like to think of, I have a filing cabinet in my brain, and then for each condition, I've got a file. And that file was developed from the first time I learned about a condition, let's say BPPV, and then it's been added to every time I saw a patient or I read about it again or saw another patient. So it's increased over time. And that illness script for that condition has things based on history, examination, investigations, and differentials that link to it. The management script extends that, and it's a relatively newer term than illness script, and it has a very structured approach to that condition. So it includes further investigations, education, non-pharmacological, pharmacological, etc. So you can see the list there. So again, this is what we want registrars to look at. We really want them to think about what's my illness script for this condition and what's my management script when I'm answering questions. So it's having a framework. So we built this template, which I'll go into in a bit more detail, and it's actually linked within the GPSA Study Skills Guide. So how does it work? So basically, you would start off with, so say you're doing neurology this week, you start off, you write down as many presentations that you can think of for neurology, because we want you to have a presentation approach, because then we're doing our interleaving approach. Next, write user mind map, dual coding. So, and you can use a framework, however you want to set it up. This is directly out of the guide. Again, you start with a blank. So you're doing retrieval mapping. You start with a blank framework, you write down the presentation, whatever framework you want to use, and then all the differentials. Then you go to the textbook and you see what you've missed and you fill that out. Once you've done that, then we want you to stratify those conditions. You want to think about, of those differentials, what's most common and what's must not miss. Okay, so you fill out the table with those based on your differential. The next step is for each of those differentials, you do an illness script. So there's a table that has different prompts, and the first prompt is you list the condition, then you might have a picture of what that condition represents to you. So I've just given an example there for BPPV. You consider the demographics. Is there a mnemonic that includes this condition? History and examination key features. So put it in your own words. What are the key features? So it's not about just writing everything from the textbook. It's actually thinking about what you just read in the textbook and then going, yeah, but what are the defining features of this condition? If I see this feature, does that increase the likelihood of that condition? Incorporating other things like video, pictures, other modalities, in terms of filling out this illness script. Investigations, not just listing any investigation you do. What are the key investigations for this condition? It might even be that you include sensitivities and specificities, so you can figure out, how do I weigh that data when I get it? The management section, filling it out, not just writing everything again in the textbook, it's using it like actually do the framework. And you might actually say to your registrar, when you're seeing a patient, I want you to have an autofill with that framework in place, or even an autofill that prompts you to do 5 differentials for a presentation. But it's getting used to using that framework, thinking about, it's easy to think about pharmacological, but there are other factors I didn't consider, like driving or non-pharmacological management options. I've also put in some boxes there for concrete examples. So as you're learning about a condition, write down examples from patients you've seen and try to write it in the way an exam question would be written. So using a STEM. So it's like a problem representation in your notes, which you then extend, and you can also write down exam questions. So as you're studying, you write questions for later retrieval practice. And you either leave that in your notes and you look at your notes later, or you add it to Anki, so you can use it as part of your flashcards. And then finally, how are you going to know you've learned something? So having these different reinforcing activities. So I put a heap of different examples there that, again, I don't want you to read it right now. It's something you can look at later, but it's just prompts to further extend that using some of those strategies we've talked about in this talk. Now the link to supervision. So I've sort of made mention of how the supervisor is involved in this. So the registrar is doing a whole lot of learning at home. What you need to do is you want your registrar to bring in that learning plan and say, okay, how are you setting up your learning in the lead up to these exams? How can we integrate that, your study plan, with our in-practice teaching? So for example, you learnt neurology last week. Let's talk about case discussion, do some bit of elaborative interrogation this week around neurology conditions, or let's do a bit of retrieval practice. I guess of all those things that I've got on the screen there, the key thing that Simon and I, where we were talking about this the other day, that we think the supervisor's role is really that refinement of clinical reasoning skills. So it's that in practice, on the ground teaching about, so the registrar learning stuff at home, the knowledge, but it's actually the application in clinical reasoning that happens in the practice. And then those key, as part of that teaching, that clinical reasoning, the reviewing of performance and the feedback and reflection that goes along with it. How can you link that to in-practice teaching? So I've put some examples again, which I'll probably mention during the talk, but this idea of, we've talked about the study plan. So when you do a teaching session, doing those 2 to 3 retrieval questions based on the last study session you did. So if you talked about a certain condition last week, why not ask a few questions? You can look up, find a couple of MCQs online, or pull out a blank piece of paper and say, okay, we talked about presentation of dyspnea last week. I want you to do a flow chart right now of dyspnea and all your differentials. So you get the registrar to do that for 2 minutes or so. And then you might use horizontal reading exercises and say, okay, well, they're your differentials. Now I want you to compare and contrast those differentials with me. Doing a bit of elaboration we talked about, so extending them, asking how and why questions. If you're doing a mini talk, so if you're doing like a quick talk to your registrar, if you've got a whiteboard, which most of us don't in our practice, but if you did, you're making sure that if you're writing stuff up on the whiteboard, or if you're using a piece of paper to demonstrate something, not only using text, but also going, let's draw a table, or let's draw a picture, let's draw a stick figure, and let's make connections or visual representations of the different key features of the condition that we're talking about. Always using a presentation format, so we don't just sit for an hour in practice teaching session and talk about hypothyroidism. So start with tiredness or dry skin, etc. And then, could hypothyroidism be a differential of that? Obviously, real life patients are really important, and supervisors are a wealth of knowledge of that. So you can talk about patients you've seen over the many years you've been practicing and give really great examples. Metacognition and reflection we've talked about as concepts, but I think that's just something that the supervisor can certainly be involved in as part of your practice. So ask them about the thinking. So if you do direct observation and you've watched a consultation, you see the registrar demonstrating their clinical reasoning, then after the session, ask them, so when you talked about this, what were you thinking? What were your differentials? How much weight did you put on that symptom versus that symptom? So just really getting them to think about their thinking. And if you see a cognitive bias, which you'll find in some of Simon's resources on clinical reasoning, talking about that, what happened when you went down that path? Be explicit about it. As I said, clinical reasoning, we think this is the key role of the supervisor. That is a talk in itself. What I've done there is this guide that Simon's written here is excellent. It has heaps of resources. There's some of them are listed there. I would really encourage you to utilize these in your teaching because, as I said, this is such a key role of the supervisor to improve clinical reasoning in that apprenticeship model that we have for GP training.
Chris, absolutely. I think the emphasis on this is so important, and really we talk about clinical reasoning being the be-all and end-all of general practice, really, and that's pretty much what the exams reflect too. So if you feel like you've got a job in supporting your registrar, it's about helping them reason effectively.
And the last one I've got here is similar to the horizontal reading exercise. This is another one that you can do as a supervisor that's really useful for clinical reasoning. And again, it's very simple. So in a teaching session, you draw up a table. So you've got the presentation, think of differentials, you put them down on the left-hand side. So this will be differentials for vertigo again. Then across the top, you put some key feature history symptoms. And then for each of the conditions, the registrar needs to rate how strongly that speaks or doesn't speak for the diagnosis. So if we're looking at specifically neuronitis, vomiting, you might write 2+, yes, definitely associated, but it doesn't really have tinnitus. Whereas for labyrinthitis, it has both. So it's that, again, that weighing of data, so weighing of symptoms and going, so if I see a patient with these symptoms, I'm feeling very strongly about this condition or not about this condition and so forth. So really nice, quick exercise you can do, and it really does tease out the registrar's understanding of those different key features and how much weight to apply them in a clinical reasoning context. So really, useful tool to use.
Yeah, and I encourage for Chris and I to put this right at the end because, I just see this as such a useful technique for supervisors to do with registrars. It may really uncover some reasoning issues. And to me, it actually really helps balance the art and science of general practice because a supervisor can say, in my experience, even though the books say this, very commonly patients do have this, or I rarely see this in these patients. So it's just a wonderful tool for that sort of discussion.
Definitely. Very similar to the script concordance testing, if you've ever heard of that. I know some of the medical schools use that. Excellent. So I think that is up to questions, Simon.
It certainly is a whirlwind, but it's always nice to think we can refer people to a resource that follows this almost to the letter, but elaborates significantly. Can I just emphasise, Chris, your script technique? I don't know how well utilised this is by registrars or understood by registrars and supervisors. I think it's such a powerful way of preparing. You've touched on it only briefly. It's elaborated on significantly in the resource. But just to emphasise, and I think the most important element, as you say, it's presentation-based. A patient presents with dyspnea, would much rather registrars learn about how to assess somebody with shortness of breath than asthma and COPD and heart failure as clinical entities. But the presentation drives the learning of those clinical topics and the comparing and contrasting occurs. So I think you spoke to that very well.
I think there's a couple of Q&A questions here, actually. So any tips revising before KFP exams? So obviously that's a very specific question to the RACGP exams, but they're all very similar. So KFP, it's a clinical reasoning exam. So by studying presentation-based, so all the stems will be presentation-based for a KFP. So if you're doing what we just talked about there, presentation-based, practicing in clinical reasoning, considering key features, that's the key for studying for the KFP. And the AKT and CCN, very similar for ACRM. So I think that would be what I would say is really honing those clinical reasoning skills. In terms of other questions there around resources, I think Murtaugh is an awesome resource. I think it's just that we need to use lots of different resources. Murtaugh is really good for a structure, I think, because Murtaugh, there's great sections on presentations in general practice, which I love, and I love his frameworks, probability, must not miss. So yes, definitely use Murtaugh, but add other things to it as well. Use your AJ2Ps if you're in the college, RACGP, use your ACRM resources, from Romeo. Use podcasts, use video for examination techniques. So lots of different, but keep it to Australian-based resources as much as possible, because that's what you're going to be examined on. Therapeutic guidelines is goal. Best time to study, yeah, I get asked this a lot in terms of, so the question here about, so you're a busy registrar, you're working a lot, particularly you might be a rural registrar doing EDVMO or other procedural type roles. It's an individual decision, and sometimes it comes down to, you sit down, you do that weekly time and you go, you know what, I can only do 2 hours a week because I've got all these other commitments. And that's where you might have to go, is it something where I need to adjust my work hours? Is it a conversation I need to have in my practice in the lead up to exams where I might need to consider going part-time if my practice is okay with that, or if I can afford that financially? Something has to give. So you've only got so much time, so you have to figure out, is it something else that I need to drop? And I wouldn't suggest that you need to drop other social engagements or sports or anything like that, but you do need to figure out, where am I going to fit this study in? Because you need to be doing enough study per week. As you can see by that study plan, there's so much to get through. So that's why we say 6 months, and you also need to be putting enough time aside each week to do it. And each week, you set up your timetable. Each week or month, you review it again. You go, well, that didn't work. I didn't get those 2 hours done after work. It's never going to happen. So that's where you go, well, where else can I fit this? Is it something where I need to do it in the morning, or I need to do it on the weekend, or wherever it might fit? But it's an individual thing, because we all have different factors that impact on our time and ability to study. Simon, you've answered the question around reading. I agree. Shades of grey cards, excellent on the GPSA website. Both colleges have curriculums. So, the RACGP has a set core unit and contextual units as well, which one of them is around professionalism, and they have great resources there. I know ACRM has a curriculum too, and it would have a similar list of curriculum statements around this stuff. So I would use college curriculums as a really good structure for your study programs, because that's what your exams are going to be based on. That's the broad structure of what a competent GP should be able to do. So I think that's all the questions that I can see there.
Yeah, somebody was complimenting you on choosing vertigo as a topic as an example, because it's so challenging.
It's so hard. I know it doesn't mean that I understand it at all. It's probably why I chose it, because it's the one that I always go, oh no, it's vertigo. Okay, I have to have a structure for this.
Lovely. Thanks all. For any other resources and up to date, we do actually mention resources in the guide. Obviously, we recommend recent journal articles, checks.
Up to date is excellent, but I just think it's too much.
Yeah.
So I think if you've got a very specific question, so say if you're in practice and you're seeing a patient and you're thinking, oh, should I screen this patient for a AAA? They're a 50-year-old male or female with a family history. That's where I would go to up to date, because I'm looking for what's the evidence for screening in this, or what's the evidence for this treatment. But in terms of study, I wouldn't use up to date as my main study resource, because it's so in depth. Like it's so heavy. So I'd be using Australian-based guidelines, therapeutic guidelines, journals, college resources. That's where I'd be sitting. And Murtar, obviously, we talked about as a resource.
Thank you all very much. Chris, again, thank you so much. We'd like to promote our community platform. I think many of you may know of this now, the details of which are on our website. For those registrars who are preparing for exams, we wish you very, very well. And for those supervisors, all the very best supporting your registrars in this endeavour, and hopefully some of this has been useful. Thanks all.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.